I'm going to very much provide a case-based kind of format with regard to discussion of my experiences using the HD grid catheter with respect to VT mapping. These are my disclosures. Most of us who perform VT ablation recognize the many number of challenges that we encounter with this procedure, not the least of which are stability. So activation and entrainment mapping is the preferred approach. It's the most kind of electrophysiologically based, but we're limited in those circumstances either by hemodynamic instability of the patient or instability of the arrhythmia, especially with repeated inductions or attempts to entrain. Substrate-based mapping has emerged as the technique of choice to try to counterbalance those challenges. And although it is certainly ideal in terms of optimizing stability, it also has its own limitations. And so interpolation effects that are acquired with points acquired from less densely spaced kind of point acquisition are really much more augmented in the absence of high density mapping catheters. And that can lead to both increased procedure times, potentially increased complications, possibly. This is an example of the differences in maps with point-to-point mapping compared to high-density mapping. You can see here with just the point-to-point approach, the interpolation effects are much more augmented here in the normal areas as well as the abnormal areas. With higher density mapping, more points being able to be acquired simultaneously. You get much more detail with respect to the actual substrate that's present. And it is, after all, in substrate-based mapping, the most essential part with which to define our ablation strategy. And then there's this emerging concept of activation wavefront dependence, which contemporary or standard methods with respect to substrate mapping are limited. Advantages of the grid are, first of all, it's a very atraumatic catheter. So you can move this all over the place. It kind of bends and conforms to whatever structures it contacts. It's basically, I can't say it's impossible, but it's very, very close to impossible to perforate with this catheter. The high density mapping that's provided, it is advantageous not only because of the fact that there are multiple bipoles, but the bipoles themselves are relatively fixed with respect to orientation with one another. And you can acquire kind of like the surgical plaque mapping kind of approach, a relatively fixed surface area of point acquisition using this catheter. And again, the wavefront dependence is decreased. There's a lot of talk about this, and I'll go through a couple slides to illustrate what exactly this means. This is work by Rod Tung, and you can see here the marked difference that will happen when we acquire points with RV pacing compared to when we stop RV pacing in the same region, the exact same region. You see here the marked difference not only in the amplitude of the voltage of the local electrogram, but also the characteristics. Abnormal here with sinus conduction, relatively normal looking in RV pacing. So if you have the catheter oriented in a certain direction, then the waveform, the amplitude of the waveform can be different. And so when it's parallel to the wavefront of activation, you have sequential activation of the bipoles or of the electrodes, and therefore the unipoles that generate the bipole signal, the difference between them is optimized, and you get the most maximal bipolar signal that you can. The opposite is true when you have the activation wavefront perpendicular to the electrode pair, because you have the activation hitting both pairs at the same time, and they cancel one another out, and so therefore there's no spike recorded on this signal. The HD wave solution that's kind of incorporated in the software with which this catheter is utilized takes the highest amplitude signal recorded and displayed. It can display both types along the spline as well as this HD wave solution. We'll go through how that might be helpful.